Welcome back. What is this, week 3 now? I think we're moving on to our third recorded week of lectures. Every bit as importantly, I'm not going to lie, this is shared lectures between 142 and 240 because we're covering the same topics at the same time, degenerative neurological disorders for this week. But also it's week 12. So that's extremely important for you to understand that this is the week that I'll be uploading the test, and it'll be an at-home test, just like before. You'll have 1 week to take it, and obviously it's an open book. Just do your best. Do your best to do it on your own, though, because while obviously it's easy to use outside resources at this time, and I'm not going to discourage that. Feel free, because it's a timed test. You only have so much time. But you really need to know this. And in the coming days, if this gets as bad as we think it's going to be, you might find yourself being engaged in the healthcare profession. And you're going to want the knowledge that because you all might find yourselves getting initiation by fire. Now, if you see people up and walking around behind me, well, you're in my house. So I've got my daughters here with my grandchildren. They've been sheltering in place for this entire time here because they live over in the country in Gaylord, out in the woods, beautiful wooded area with absolutely no internet. And I guess internet is an essential component to life. We obviously, we wouldn't be able to do what we're doing without it. Actually, Jimmy Kimmel was laughing last night. If he had to choose between internet and running water, he would choose internet right now and drink from his pool. That's how dependent we've become. And it's true. We couldn't do the things we couldn't do. My grandchildren are going to school online. My daughter's an educator herself. She's a high school teacher. She's making her curriculum online. So don't feel like the Lone Ranger. I know you guys are going through, this is a hard time, but imagine if you would, all those, some of you who have children, you're going through this and you know exactly what I'm talking about. Now I'm recording this for the first time with a video. So you get to see me in my relaxed garb. Look at this. Yeah, hey, you gotta love Ford. Okay, they're helping the country, and just a hoodie. Wow, when have you ever seen me come to class in a hoodie? Yeah, actually, I'm kind of in my pajamas. This is getting bad. It's almost like we live in our pajamas every day. I wouldn't call these pajamas. They're just cozy sweatpants and Crocs. Believe it or not, I'm wearing Crocs. So go figure. I got to admit this teaching style is really comfortable, and I should probably adopt it for my classroom. But we'll see. Anyhow, moving along, let's get to the chapter, the learning objectives. I always start every single chapter. I start telling you guys the learning objectives. I cannot stress once again, especially with this time now being that so much is placed on you for self-study. One of the best ways to self-study is write out each learning objective, I would say write one learning objective per page. Leave the rest of the page blank. Then as you read the chapter, answer the learning objective. Write your narrative in your words how to answer that objective. That way you memorize it in your way, your method. So go ahead and write out those objectives, write out the answer to those objectives. And also, that's at the beginning of the book. Don't forget the end of the chapter as well. The end of every chapter has key points. Go over those key points. Those are the lessons that you're supposed to take away from this chapter. Honestly, it's extremely important for you to get that, because that's what your boards are going to be based on, those key takeaways. And this is what you need. Yes, you need this knowledge to perform, but in order for you to get into that hospital to perform, You have to pass your state boards, and I want you to. So let's get you prepared. All right? So start with the learning objectives. All right, we're going to go over degenerative neurological disorders, and we're starting off today with Parkinson's disease. Now, Parkinson's disease is a degenerative neurological disorder. The cause, and you're going to find the cause in a lot of these degenerative neurological disorders are unknown. A lot of them are unknown etiologies, but it does seem to involve or cause the degeneration of dopamine producing neurons, which means you get the imbalance between dopamine and can anyone else tell me the other neurotransmitter? Anyone? Yeah, I still don't know how to do the hand raising thing with this. So acetylcholine, right. So those two neurotransmitters kind of have to stay in balance. When they're out of balance, bad things happen neurologically. And this happens because the dopamine isn't being produced. Excuse me, this dry cough, runny nose, difficulty breathing. I don't know what I got going on. It's killing me. All right, so the most common form of Parkinson's disease is idiopathic. Idiopathic. Now, all that means is we don't know what's the cause, the underlying etiology. And I already told you we don't know the underlying etiology for most of these neurological degenerative diseases. However, we do know that when you do have the imbalance of the dopamine to the acetylcholine, that the neurological imbalance that is going to occur is going to lead to some external effects. Those external effects are known as extrapyramidal system, and those will cause control of things like coordination, balance. So this is why you end up seeing the patient will have typical presentation. Often you'll see this pill rolling. You see my fingers moving? You'll see the fingers just move involuntarily. You'll see a tremor in the hands, a tremor to the hands with pill rolling, okay, pill rolling. And if you see them walk, they've got a front-leaning gait with a shuffle. So they don't have a normal gait. It's because their body is rigid. So they're going to have this rigidity component to their presentation. As a matter of fact, their presentation is going to have a triad. Now a triad is 3. So there are 3 things you need to remember for Parkinson's disease. Now if you're in the 240 class, you should be reciting those 3 things already. If you're in the 142, then you're thinking, okay, well, I don't know what the hell these are because I didn't bother reading the chapter because you guys never read the work beforehand. Well, it's all right on page 554, and it says under signs and symptoms, a triad of symptoms is characteristic of PD, Parkinson's disease, which is tremor, bradykinesia, and rigidity. You have to know those. That triad is important for you to understand the concept of what's going on with the extrapyramidal system, the motor structure, and the dopamine to acetylcholine balance. You don't have enough dopamine, so the balance goes off. And then you end up with these extrapyramidal effects, the triad, the tremor of the body. The bradykinesia means slow, stiff movements. The rigidity of the body because of those slow, stiff movements. The pill rolling of the hands. The forward-leaning shuffled gait. Well, think about this. It usually happens in people, elderly, typically. So they're geriatric in nature. They're not the most agile people that I know of. I know I kind of resemble that because I'm not nearly as flexible and agile as I used to be. Okay, so you take an older person, you make them more rigid, more stiff, less coordinated. What does it sound like I'm at risk for? Possibly falling down? Yeah, we've all seen the commercial. Oh, I've fallen and I can't get up. Why? Because they're old. They become rigid. They become uncoordinated. These are things that coincide with degenerative neurological disease of Parkinson's. And then they fall. And what are geriatric patients, especially geriatric women? Brittle. They also usually have some component of osteoporosis going on. Their bones aren't nearly as dense or as strong as when they were younger. So what happens? They fall, they break their bones. Boom, next thing you know, they've broken their hip, they've broken their femur, they've broken some, their arm because they fell outstretched arm. Boom, right? They're falling down because of the Parkinson's. They're at risk for falling. That means they're at risk for injury. So these are things that you have to consider if you have a patient with Parkinson's disease. And here we're talking about in this figure 24-1, which is located in page 554 of the book. Now, this shows you got the two chemical agents that are responsible for neurotransmission, acetylcholine and dopamine. They balance each other out. If they don't, and one outweighs the other, you end up with some type of neurological deficit. In this case, you have the depletion of the dopamine, which means you have too much acetylcholine, and you end up with the triad of tremors, bradykinesia, and rigidity. This is just an example of the type gait. I know this. You're looking at this photo and going like, oh wow, that looks like Mr. Kutchman. Yeah, it's just another old bald guy on a screen. But at the end of the day, you see that forward-leaning posture, that shuffled short step walk. Arms don't swing as much, so a reduced arm swing. Tremors throughout the body, especially the hands, and sometimes you'll see the little tremors with like this, and it looks like pill rolling is what we call it. So how do we diagnose it? Primarily through observation of the characteristics of the symptoms. It's pretty prevalent when you see these symptoms at hand, and you know it when you see it. But we can also do an MRI and look at the anticholinergic dopamine agonists and antagonists and see. In other words, we could do an MRI and see what is the uptake of dopamine in the brain. And that will kind of let us know. Matter of fact, if you look on page 555, at figure 24-3, you'll see a positron emission scan, which shows a reduced uptake of dopamine. And that would indicate that patient with Parkinson's disease. So there's an example of how an MRI can assist in this diagnosis. But however, most of the time, the diagnosis is made but through observation and characteristics of the symptoms. So complications that can involve, well, obviously dysphagia, difficulty swallowing, limited mobility and immobility because of the extrapyramidal effects that occur with the triad that I already spoke about. In addition, you can have constipation, urinary incontinence, and insomnia. What do we want to do is we want to prevent complications. How do we treat it? We treat it through medications. If you look on page 555 and the table 24-1, you'll see the drugs commonly used for patients with Parkinson's disease. And the big drug you'll see at the very top of the list is levodopa. And you also see Sinemet, where you have levodopa and carbidopa. And you'll find out, as you already know, you almost always treat with a combination drug for Parkinson's. So these are the medications that you typically see. And these medications help because they increase the production of the dopamine, and therefore they decrease the presence of the tremors, the rigidity, and the bradykinesia by improving overall motor function, therefore enhancing the safety of the patient overall. Plus, this is going to sound weird, but you can encourage the patient to help decrease the tremors by having the patient do enhanced voluntary movement. So they'll do this, and then you tell them, could you reach for that spoon? And they reach for the spoon and they stop. Why? Because the muscles are doing a voluntary, not an involuntary act, and they can control it. So when they go to do something physical, the tremors stop. So you can actually help these people, especially in nursing homes, by keeping them engaged. That's why sometimes you'll go into nursing homes and you'll see the more experienced nurses, they've got patients that are sitting there folding washcloths. And you think, wow, man, that's like child labor in reverse. That's geriatric labor. They got these old people folding their laundry. No, they're keeping them engaged with minor motor skills that help stop and reduce the tremors. That actually increases the patient safety because the tremors progress and it gets worse. So what do? Keep the patient engaged with enhanced voluntary movement. So what do we learn? How do we do it? We want to prevent complications. How? Medication, therapeutic regimen, most common drugs. Keep the patients engaged, voluntary movement. Think safety. You want to prevent any type of injuries through falls. All right. Also, in addition to medication, you can look at diet, movement, exercise. We've said before that they have difficulty swallowing, so therefore you want to watch for excessive salivation. Excessive salivation can lead to aspiration pneumonia, and you really don't want that, okay? So we want to keep an eye on that. Here's just an idea of what we can do with our unlicensed personnel, our nurses' aides. Basically, a lot of these slides, time and time, tell you again, do not dump the hardest patients on your nurses' aides. They need nurses to monitor them. Your nurses' aides should be taking care of your easier walkie-talkie patients. You should be taking care of the harder patients. All right? Okay, moving right along. Multiple sclerosis. So let's see, that'll be on page 559. Multiple sclerosis is a chronic inflammatory disease that causes demyelination of the central nervous system. Now, the thing about this is there are 4 types. What you want to look at is you want to look at the table on page 560, bottom left-hand corner. And you'll see the 4 types are relapsing remitting, which is the most common. And this, you need to know that. You know that at a minimum, know that relapsing remitting is the most common type of multiple sclerosis. You need to know that it's clearly defined by relapses of acute worsening neurological function. Partial or complete recovery occurs with these remission periods. Then you have the primary progressive. It's slow, but almost continuously worsening. Secondary progressive, the initial period of relapsing remitting, followed by a steadily worsening, course. And then relapsing progressing. The disease steadily worsens from onset, but there are clear acute relapses with or without recovery. Now, there's a lot of different theories about multiple sclerosis. However, to be known that first and foremost, there is no cure. Once diagnosed with multiple sclerosis, there is no cure. They believe that the body's immune system attacks the myelin sheath of the nervous system. This demyelination that occurs, all right, when the immune system attacks it, the myelin sheath becomes inflamed and then deteriorates. After it is eroded by the inflammation, it's replaced by scar tissue, which never works as well as the initial myelin sheath. Remember I said before, you have to think of the nervous system kind of like an electrical system. That electrical system, you know, like you see your electrical wires in your house, they need that insulation covering the wire. If that insulation is not there, what happens? The appliances short out, right? And then they don't work. Well, if the electrical system inside your internal body, the insulation is the myelin sheath, and it's eroded because your immune system has attacked it, and now that insulation is no longer there, it's replaced with scar tissue that doesn't function, your impulses short out, and therefore your nervous system breaks down. It short circuits, and it continues to get worse. So what are the signs and symptoms of something that's shorting out? Well, most common manifestations are motor dysfunction, because obviously the nervous system's impaired and it's not working. So you're going to see weakness, paralysis. This is going to happen to the extremities, the limbs, the trunk, the neck. You might see double vision, diplopia, sensory dysfunction, numbness, tingling, paresthesia, progressing to paralysis, problems with coordination, ataxia, tremors, slurred speech. This can mimic a stroke. Be careful, because people who have MS can still have strokes. Don't get caught into thinking that it's MS. If someone has signs and symptoms of a stroke, treat it as a stroke, okay, until you rule it out. Understand, you always treat that what can kill you first. Unfortunately, MS can kill you as well. As it progresses, you'll see mental changes, fatigue, and finally, the patients typically do succumb to the disease, or they can. Now, I'm not going to say you can't live a full life. With the medications that they have nowadays and the treatment plans, there are plenty of people who live full lives with MS. That's not to say that they don't live their life with medical complications or without medical complications. They have issues, but luckily there are new medicines coming out all the time, and medical science has really helped progress. Used to be, if you were diagnosed with MS, it was almost, you know, right out of the gate considered fatal. Now you can go for quite some time and almost live you can actually live a productive life. That being said, it's still a challenge. So understand that we believe that it's a virus or bacteria, and then the autoimmune system just goes haywire on your own body. And that here are some of the issues that go on. So I already talked about some of the clinical signs and symptoms. How you can, typically they have the elevated gamma globulin, and for diagnosis, an MRI usually shows characteristics of white matter lesions scattered throughout the spinal cord or brain, and this will confirm the diagnosis. It used to be the diagnosis was confirmed much like Parkinson's through observation, but with the advent of MRIs becoming more prevalent and more available, we can actually have more confirmed diagnosis. So treatment is modifiers. Obviously, interferon can help with the regulate the immune system. We also can use anti-inflammatories like steroids for the acute exacerbation that occur. Exercise has been shown to help, because one of the problems is weakness and fatigue. So exercise has been shown to actually help in this matter. And it also helps with the spasticity and the coordination issues that come along with the neurological degeneration. So you can see what a normal neuron myelin sheath will look like along a neuron or neural pathway. And then over time, the inflammation erodes the myelin sheath itself. And you can see there it progresses, and as it progresses, the neurological deficits increase. Okay, so like I said, some of your nursing diagnoses then especially for the RN level students, you're now going to be developing nursing care plans for these patients. You have to think along the line of, fatigue, impaired physical mobility, self-care deficit. Why? Because the patients just can't care for themselves. And of course, with sensory motor deficits, you can always have urinary incontinence and sexual dysfunction. Education is key, not only for the patient, but for the family, because these patients require a lot of support. Just like, Parkinson's patients, obviously, you got to think about the same. So education, there is the National Multiple Sclerosis Society and local support groups that help. Alzheimer's. Alzheimer's is a form of dementia that's caused by pathological changes in the brain. Unfortunately, Alzheimer's can be detected only through autopsy. The cause is unknown. It's a considerably progressive disease. There's a lot of research going on for Alzheimer's. Yeah, the disease has a very slow onset, but can progress at various rates depending on the individual. So it's something that it's individualized in nature. Typically, it has a lot to do with memory and cognitive function, in the sense that over time, people lose their short-term memory, and they lose more and more of their short-term memory, and to the point where they forget who they are. They forget who their relatives are. Basically, everything is erased. It's a sad disease because they don't recognize their loved ones. It's a terrifying disease because they are frightened. Because of the way it progresses, you could be driving home, stop at driving the same route you've driven home from work your entire life. Stop at a stoplight. 1 minute you're on your way home. Next minute you have no idea where you're at. You don't know you don't know which way to turn. You don't know where you are. You don't know who to call. You don't know what to do. You're just panicked. This happens, or patients just wander. And when I was living in North Carolina, we had a little old man who lived next door to us, and when we first moved in, he was a super nice little old man. Just a really nice southern neighbor. But the next year, things changed. All of a sudden, he just wasn't himself anymore. He didn't know who I was anymore. And it wasn't always. It was just sometimes. And then, next thing you know, he's wandering the neighborhood aimlessly. And sure enough, Alzheimer's had progressed. And you saw this person who was interactive, bright, just degenerate before your eyes within a matter of a year, to needing to be put into a home. So these are sad cases, obviously. Oh, ALS. Now here is your task for the week, your homework for the week, that I will give you all credit for a quiz, if, but you have to email me. You have to email me with at least one comment about the movie, The Theory of Everything. Now, The Theory of Everything is a movie about a physicist. God, I always forget his name, too. I'll ask my daughter. She'll probably remember. What's the physicist's name?
It is...
She's Googling that shit. She knows how to GTS better than anybody.
Oh, yeah.
Because
Stephen Hawkins.
Stephen Hawkins, yes.
It's a phenomenal movie.
Pardon me?
I said it's a phenomenal movie.
Yes, it is a phenomenal movie. Get back to your classwork.
Oh, yeah.
So she's working on her curriculum in the other room. So Stephen Hawking's, it's about the story of his life. But it really does a great job of showing you the progress and of the, not only the disease, but the impact that that disease then has on you as a whole. Now, the thing about ALS, it's also known as Lou Gehrig's disease because he was one of the very first. Obviously, if you're from my generation, I would tell you to watch the baseball movie, the Lou Gehrig story, which is, hey, you can watch that one too, either or. I don't care. You can watch the Lou Gehrig story, or I do think The Theory of Everything does a much better job. I forget who plays him. He does a good job. Somebody Patch. I can't remember. Anyhow, he also played in those Harry Potter movies, but the point being is this is a progressive neuromuscular disease with a degeneration of the gray matter at the anterior horns of the spinal cord. So what this means is this disease progresses very slowly. If any of you know someone with ALS, you know this. Actually, one of my friends from high school, his wife was just diagnosed with ALS. And you start to lose motor function. It starts with, basic weakness in the extremities. As the extremities get weaker, the muscles get weaker. You lose voluntary muscle control. So it just starts off with a general muscle weakness. So a lot of times it's diagnosed through people just reaching out for a cup, like this, reaching out for this Diet Mountain Dew that I haven't quit drinking yet, right? But as you reach for it, you drop it, and because you don't have a tight enough grip on it, or they stumble and fall because they're not picking their legs up, and they're actually tripping over their own feet. So they move from this muscle weakness to complete paralyzation, where their body just shuts down and their entire body shuts down. Every muscle in their body ceases to work, or eventually over time. Well, there's two problems with that. When all the muscles in your body shut down, okay? One, you need muscles in your body to work so that you do things like, I don't know, breathe, right? Remember that big muscle, that diaphragm that moves up and down, that lets you take air in and out of your lungs? Yeah, that's a huge one. And what happens when you're not up and moving? You're more prone for respiratory illness, you're more prone for disease, you're more prone to pressure ulcers. So all of the secondary effects that occur because their muscles simply stop working. But here's the real kicker that makes this disease so horrendous. Their cognitive ability never changes. In the other diseases, cognitive ability is changed. There's a change in mental status, not in ALS. In ALS, you stay completely intact as your entire body shuts down. Your entire body betrays you completely, but you're every bit as sharp intellectually as you ever were. Imagine that. You become a prisoner in your own body. That has got to be a horrendous torture. So, imagine, well, how would you take care of? Well, you got to take care of the patient, and you got to take care of, as the muscles progressively get weaker and weaker, and they eventually become paralyzed. They eventually will be placed on a ventilator because their respiratory drive will stop. All the muscles for the respiratory drive will shut down. It's just, you have to treat them symptomatically as they progress through the disease until they succumb from it, until they eventually will succumb of it. Now, Guillain-Barré syndrome is relatively rare. It is it usually follows a viral respiratory infection, and it's usually about 2 weeks, about 10 to 21 days after a viral respiratory infection has occurred. The body will begin to notice weakness starting at the lower extremities, progressing to paralysis, and it'll continue all the way up. It can continue as high to the point where they too will need to be placed on a ventilator. The difference being is where Lou Gehrig's disease, ALS, is usually the entire body, the arms and the legs will show weakness. All muscles will show weakness at the same. With Guillain-Barré, it starts at the lower extremities and moves up. That's the key indicator. All right. Also, Guillain-Barré is transient in nature. It's typically transient in nature. It'll run its course, and then everything will go back down. And now, it takes time. I'm not saying it's going to happen within a month. I mean, the recovery phase for Guillain-Barré can be up to 2 years. But, because you have the acute phase, okay, where the patient, the goals are to sustain life in the acute phase. You're trying really hard, because this is where the respiratory drive is impaired. So you're just working to keep them alive. And then once you're past the acute phase, you want to move to the basically the static phase, which is the care is concentrating on preventing any complications from arising. Okay, now that they're on the ventilator, I want to make sure that they don't get pneumonia, right? That's the static phase. Then as the disease lessens and the patient starts to recover, you move into the rehabilitation phase. And this is a gradual phase. They can suffer relapses primarily because they try to get back to normal too fast. Because this recovery phase could take up to 2 years to get their muscle strength and coordination back. So this is a devastating disease, but not nearly as devastating because this is not a life sentence like ALS. This is transient in nature. Also, there's a lot of healthcare workers that I've come across will not do vaccines, especially flu vaccines, because 1 year there was a very low percentage of Guillain-Barré that they thought was associated to the influenza vaccine. The studies have come out. Read the evidence-based practice. Okay? You are less likely to get Guillain-Barré if you get the flu vaccine. You are more likely, have a much higher chance of getting a viral respiratory condition if you have not been vaccinated. So please, 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 I beg of you, and this is, I'm extremely talking to the RN levels right now, do your homework on vaccinations. Do your due diligence and read the true research, not what you read in those stupid magazines that ask some starlet about her opinion because of some kids that might have autism. No correlation, none. Studies have been debunked time and time again. So do your homework as a true healthcare provider. Know the facts, educate yourself so that you can educate the populace. And where are we going to be if people refuse, if they come out with a COVID-19 vaccine and people refuse to take it? This virus isn't going to go away. Hell, the guy, Dr. Fauci says already from the CDC, it's going to be cyclic in nature. Now, if you look at the R naught of the COVID-19, then it's 2.3. That means for every one person who gets the disease, they usually pass it on to 2 to 2.5, actually 2.3 people before they realize they have symptoms. That's before they realize they have symptoms. The normal flu has got an R naught of about 1. Normal flu has a mortality rate of about 0.1%. COVID-19 has a running mortality rate of approximately 1 to 2%. What does that mean? Well, if they anticipate 50% of the state of Michigan to get COVID-19, our population is 10 million people. That would mean 5 million people would get the disease. But that's okay. Only 1% of the 5 million would die. That's 50,000 people in the state of Michigan alone. So you tell me, the only way to stop the disease is herd immunity, when the disease no longer has the ability to infect people because they're immune to it. Well, you get immune by one of two ways. Either getting the disease and recovering, and oh, by the way, coronaviruses, your immunity only lasts for 1 year, approximately 1 to 2 years. That's why you get an influenza shot every year, because certain diseases, immunity doesn't last forever. That's why you have to get booster shots. And I know I'm off on a tangent, and this has nothing to do with Guillain-Barré syndrome. But hey, you guys have missed me, and you missed my probably crazy wild tangents, and you know how I can go off on the anti-vaxxers, okay? For the life of me, I can't understand how you can be in the healthcare field and be an anti-vaxxer. I just don't believe it. Sorry. I just look at you and I say, obviously, you have not done your homework. You have not read evidence-based practice. Okay. We know are the signs and symptoms. I already told you. One of the things, that I didn't tell you is for treatment. One of the most prevalent treatments for Guillain-Barré syndrome is plasmapheresis. Now, plasmapheresis can help in the sense that the plasma is removed and washed. This helps to remove the antibodies that are attacking the person's own body. You see, this is the person's own body about 2 weeks after having a viral syndrome. It's their immune system going haywire again. So by doing plasmapheresis, you remove some of those antibodies and the body's immune system goes a little less haywire. And you hopefully, in a couple weeks, recover. And obviously you want to support this patient throughout, and that includes things like nutritional support. And all of the other, same nursing diagnoses for RN level students, you need to think about what are the, nursing diagnoses that are going to be applied with this disease, like impaired nutrition, acute pain, self-care deficit, those type. All right, polio. Oh my God, we're right back to my vaccine. Polio was almost eradicated in our country, almost totally wiped out. Now, I actually had a teacher who walked with a limp because when she was older, when I was young, she was older. But when she was a little kid, she got polio. And polio used to kill a lot of children. And it used to leave permanent residual effects, crippling effects. Polio destroys the motor cells of the anterior horn of the spinal cord. Remember, that's that same anterior horn we were talking about during ALS. Now, if you look back on ALS, you look at the anterior horn of the spinal cord and lateral cranial nerves degenerate. Well, here, it's attacked. Now, sometimes it's residual. There's residual deficits, and sometimes there isn't. It all depends on how bad the person has, how bad their case is. Just like this COVID-19, some patients, about 80% actually recover. Only about 20% require hospitalization. But then of that 20% that require hospitalization, you have a percentage that then require about 5% of the 20 are requiring ventilators. Well, that's a huge number. When you start talking percentages of, huge, the country. Well, it's the same here. So that's how it worked. Quite a few people did just have temporary residual effects. Quite a few people did die, and we almost had this beat. It's an onset of weakness, pain, fatigue. It's been about over 30 years, but it's starting to come back. And it's frustrating when a generation worked so hard to eradicate something to see it coming back just due to misinformation. Huntington's. Now, this link isn't going to work because this is a video that you're watching. But go to this link on YouTube at the bottom of this screen. Okay, I will see if I can move my video out of the way. I'm going to try something here. Nope. Okay, there. Now, hopefully you can now see the entire web address and watch this video. Okay? Hey, I'm back. So, it's a genetically transmitted degenerative neurological disorder that is, unfortunately, it's autosomal dominant disorder, meaning that if the children of a person who has the disease automatically has a 50%. So if you're in a relationship and you have the disease, or your spouse has the disease, your significant other, 50% of your children will automatically have the disease. Now, that, or 50% of your children will automatically inherit the disease. And since it's a prominent, it means it's a dominant disorder. It means it's more prevalent that they'll actually have the disease and not just be a carrier. Watch the video. The video outlines the disease perfectly. And they have these Huntington's, also known as Huntington's chorea. It's abnormal jerky movements. It is in the community. There are people who have it, and I know for a fact, up north. I was talking to one gentleman whose brother died of the disease, and he said that they just try to keep it quiet in the family because they just believe it's God's will. I believe, that knowledge is power, and before you enter in a relationship, there should be full disclosure. So before you enter into a relationship, ask about family health and, family issues, because these are things that will impact your children. Okay? And it's only, you shouldn't be finding out after the fact. Oh yeah, I had a brother who died of that. Um, that's, yeah, I don't know. It's just, it's hard, but at the end of the day, the numbers are just what they are. And if you're willing to take that risk, that's up to you. But understand, you're inflicting that onto another generation as well. So watch the video. It's well worth watching. Myasthenia gravis. This is something you're going to see more commonly. Obviously, you don't see a lot of Huntington's chorea, but you do see a lot of myasthenia gravis. It literally means grave muscle weakness. The muscles, respiratory muscles, the cranial nerves are affected, resulting in muscular weakness. It can be mild or severe. Between 80 to 90% of the patients with myasthenia gravis have an autoimmune disease in which the circulating autoantibodies are directly against the postsynaptic acetylcholine receptor of the neuromuscular junction. So this is typically, so it's yet another autoimmune generated disease. It is typically seen with severe muscle weakness, ocular or vision items that occur are things like double vision, diplopia. Also, ptosis, where you get a droopy eye syndrome. If you look at the picture on page 565, bottom right-hand corner, you'll see that they'll have a single eyelid that droops. And that's a very common sign. And of course, hoarse voice. Those three things are very common with this disease. It does not affect their level of consciousness. Now, it's established, the disease is established through observation, H&P, history and physical. Also, you can perform a Tensilon test. The Tensilon test is divided into 2 injections. They're administered, and if there's a marked increase in muscular strength within 1 minute of the second injection, then that patient is positive for myasthenia gravis. So the treatment, well, that's the ptosis I was telling you about. That picture. Treatment, once again, plasmapheresis. We want to try to, since this is an autoimmune disorder as well, we want to try to remove those autoantibodies, and also anticholinesterase therapy can be helpful. But plasmapheresis is one of the most prevalent treatment. The anticholinesterase agents temporarily increase the muscle strength by allowing the acetylcholine to work, but that is a treatment and not a cure. So remember that can help with the muscle weakness, the anticholinesterase therapy. Once again, the IV immune globulin can be given to help with the autoimmune issue. Nursing management. Well, obviously, fatigue is going to be one of the nursing diagnoses. You want to determine patient knowledge and education. You want to assess their muscle strength because muscle weakness leads to risks like falling. So you want to check their overall muscle strength and determine the patient's abilities and coping mechanisms. Things like ineffective breathing, ineffective airway clearance, disturbed visual, imbalanced nutrition. These are all nursing diagnoses you're going to have to consider and implement as needed. Obviously, physical and emotional stress, both patient and family education, and understand that a patient with myasthenia gravis can go or enter into a myasthenic crisis. That is extremely important. If they were to suffer in this, you have to be cognizant that their body can, trying to find it in the book so I can cover it in better detail, but their body can go into a myasthenic crisis, which can be an emergent event. These are the patients who are brought straight to the emergency room. They are going to have extreme difficulty breathing. They are going to, they're going to basically, they're going to exacerbate the problems. Now, they can go into crisis also due to drug overdose, or if they were to have too much anticholinesterase, then it can go the opposite direction. So they can become critically ill and need immediate medical attention. Patients with myasthenia gravis should wear a medically alert bracelet, and they need to be monitored. The underdosage of an anticholinesterase agent can precipitate illness. Stress factors can relate to that, can cause that underdosage. Signs and symptoms should be, relayed immediately. If you look in box 24-2 on page 567, it goes over the cholinergic crisis and then myasthenic crisis. The cholinergic crisis is generalized weakness within an hour of the dose of the medication, dyspnea, increased bronchial secretions, poor tongue control, difficulty swallowing, restlessness, anxiety, irritability, diaphoresis. Myasthenic crisis. This is an increase in the myasthenic gravis symptoms after failure to take the medication as prescribed. This is more difficulty swallowing, diplopia, ptosis, dyspnea. So either direction, okay, that's why you have to walk. It's almost like a tightrope with this medication regimen, and either way can throw you into cholinergic crisis or myasthenic crisis. So you have to monitor the patient very, very closely. Either direction, and you've got yourself an emergent event that could be life-threatening. Okay, so there might have been a little disconnect there at the end of the last slide. If there was, I apologize, because you never know when this presentation is going to end, and I'm really just learning this technology. If you have any questions, please feel free to email me. I hope this helps on both fronts. Read your textbooks, and remember, I'm going to open test 12 over the next week. So from this Thursday till next Thursday, the test will be open for you to take at home at your leisure. So I'm looking at this Thursday being April 2nd. So this is no April Fool's joke. You got a test that is due by April 9th. All right. So remember, let me get the textbook here. For those of you who are in my NUR 240, I'll be emailing you separately on what I'm going to cover on the test. 142, you already know what's covered on the test. If you have any questions, feel free to ask me. It'll be 50 questions, multiple choice. All right, so that's it. hope you all are hanging in there. Take care, and remember, email me with any questions or concerns at this time. Take care. Bye.